Thank you for the opportunity to share this work that is Mission Thrombectomy's advocacy arm to try and see what we can do to improve awareness of Mission Thrombectomy and access for the people in the US. So I'll be sharing with you what we've been doing so far and what's on plan for the coming months and going into the next year. So we've heard time and again today that stroke is an immense problem with a fantastic solution for large vessel occlusion, and yet we are only treating fewer than 3% globally for those with large vessel occlusion, even though it is a life-saving treatment and it is the standard of care. So clearly it is not a common availability for patients throughout the world. The evidence for this treatment is incredible in that the effect size is number needed to treat of 3 to 8 based on the thrombectomy trials that came out between 2015 and 2017 and still continues to be a very powerful treatment for those who now also join the ranks of patients who are eligible for large core infarcts and those presenting with posterior circulation strokes. When you compare this with statins or PCI, you can see how much more powerful this is and hence why it is the standard of care. It has an impact compared to medical treatment in terms of improving the outcome for patients, minimizing disability and death. In the US itself, roughly the incidence of those with ischemic stroke is 216 for every 100,000 people. Amongst those with large vessel occlusion or medium vessel occlusion, 44 out of every 100,000 people are thought to have strokes due to this intracranial occlusion. Yet, when you look at studies that have looked back to see how many patients are actually being treated with mechanical thrombectomy, that number is a fraction of the patients who are eligible. So approximately 10 to 13 people per 100,000 get mechanical thrombectomy. So that's about 25%. So why is such a standard of care so uncommon? Is it access to endovascular capable stroke center? And again, studies have looked at this where when you look at the map of the USA and plot how far away is any individual from an endovascular capable center, the first map shows that they're about 60 minutes by driving distance for about half of the population. If you include air travel or air transport for these patients, then you increase more the reach for the patients to about 62%. Combining ground and air gets us about 65% access for endovascular capable stroke center for the population of the US. So that still is fairly less compared to the number of patients who do present with large vessel occlusion and medium vessel occlusion. Multiple professional societies, including SVIN, SNIS, and EMS agencies and societies have recognized this and worked together to produce a consensus statement recommending regional stroke destination plans in rural, suburban, and urban communities to improve pre-hospital detection of those thought to likely have large vessel occlusion. When pre-hospital triage tools are used to screen for LVO, the odds of mechanical thrombectomy access increases fourfold than those patients who don't have this tool employed. So in the stroke chain of survival, the pathway guidelines recommend screening for stroke using validated screening tools. And if the tool registers positive for large vessel occlusion, then for a stroke, then the recommendation is to use one of the screening tools. And if they score at or above the threshold for likely LVO presence, then the guidance is to transport those patients to local stroke center destination protocol. There are many severity scores that have been published, and EMS regions are recommended to choose a single severity score, employ its use, and monitor adherence to usage as well as accuracy. So this is broken down by access to centers, so rural, suburban, and urban. And rural population is defined as under 25,000. Suburban is between 25,000 and 50,000, and urban is over 50,000. And like Dr. Novakovic talked about, these patients, if they present to a non-capable center and are within 30 minutes or within 60 minutes to a capable center based on either rural, suburban, or urban transport, then the guidance is to take them should they score on the screening tool. So a study published in 2020 looked at the use of one set scale, the RACE score, and if patients in their triage pre-hospital region scored 5 or more, they took those patients to a endovascular capable center, versus those scoring less than 5 were taken to a standard stroke alert hospital that was close to the patient. Looking at these patients and who received mechanical thrombectomy, compared to those who went to the stroke alert hospital, those that used the RACE alert and were positive for 5 or more, the difference in those receiving mechanical thrombectomy was substantial. Without the tool, only 3.3% of the patients were identified that needed thrombectomy and therefore had to likely be transferred, versus 25% of the patients based on the pre-hospital screening tool were taken to the endovascular capable center. This study was done between 2015 and 2018, right after the series of trials that initially made thrombectomy level 1. So this tells us that a real-world experience shows that utilization of pre-hospital stroke screening tools can increase the selection of those patients who might have large vessel occlusions and therefore get them to the destination hospital right away rather than delaying their treatment. And the study also looked at the times that the patients received the treatment from the time of dispatch to the time of reperfusion, and almost 100 minutes was the difference between those who were screened using pre-hospital tool versus those that had a dichotomous stroke alert screening pathway. Another group also looked at the number of patients that presented from 2015 onward with large vessel occlusion and medium vessel occlusion and the rates of thrombectomy since 2015. So in 2021, when the guidelines were published, there were about 39 patients, or a 38% utilization rate for mechanical thrombectomy. The study also estimated the proportion of patients who may be eligible in the future for large vessel occlusions and medium vessel occlusions, and some even including M2 occlusions. And in the year 2025, they estimate this to be as many as 57% of the patients. This is out of a possible 144,000 eligible patients if they were to use the screening tool. But as you can see, that's still only slightly more than half of the patients who might be candidates for thrombectomy. Another study looked at the modeling of implementation of optimized stroke transport protocols. And if they were implemented 100% of the time, then you increased the number of patients having excellent outcome by 36 and also improve cost savings. So you're helping the patients, and this is coming at improved cost to the community and the nation. So We do have the centers. The treatment is effective. So what are the barriers? So Dr. Novakovic already mentioned some of the barriers, and they seem to be somewhat universal, regardless of rural, urban, or suburban. So there is lack of timely pre-hospital recognition of stroke symptoms. And that's primarily due to patient and public awareness deficit and illiteracy and EMS underutilization and EMS training on LVO recognition and destination triage. If you look at access to trauma level 1 and 2, that's 91%. Access to PCI is about 84%, but access to EVT centers is only 65%. So if this were a report card, this would be a D. So barely above fail. And other factors that are resulting in barriers to timely treatment for thrombectomy include futile transfers due to delayed diagnosis and transfer needing to be made to an EVT center because the patients initially were taken to the closest center where they could not get that treatment. In a European registry, 45% of such transfer patients were transferred without benefit for mechanical thrombectomy or being candidates for the same, and 11% of those patients were due to delays in transfer. So other barriers were also mentioned, and those require significant financial and time and distance strategies to be overcome. But what can we do today with the existing infrastructure and personnel? And that is EMS training on LVO recognition and destination triage. So our group, Dr. Kez and Dr. Bajesh and co, published a study recently, earlier this year, where they partnered with EMS World and looked to see what the knowledge was in terms of recognizing LVO patients and whether they've had training. So in the US, there are over 1 million licensed EMS professionals, and 38,000 of them are subscribers to this EMS World organization. Survey was sent out to those members, and 1,800 of them opened the survey, 1,100 completed the survey for a response rate of 2.9%. The respondents were overwhelmingly paramedics and EMTs, so these are highly trained first responders. 56% of those who responded transported fewer than 10 patients with a stroke in the preceding year. So when they were asked, are you familiar with an LVO scale? 4/5 of them had actually heard of it. And 2/3 of them had received some type of training. So based on this, they were asked knowledge questions. And there were 3 knowledge questions. 2 of them were, which of the following statement about large vessel occlusion is false, and which is considered standard care for LVO stroke patients up to 24 from last known well? Only 1 in 4 respondents was able to correctly answer both questions. And a third question was, which of the following stroke centers must have neurointervention availability 24/7? And only 1 in 9 was able to answer this correctly. Of those who had received no training, 1 in 6 got these questions correctly. And of those who did receive training, twice as many were able to answer it correctly. So it does show that with training, the knowledge base for LVO stroke screening utilization does go up. They were also asked, what is the most important step in reducing pre-hospital field problems in managing patients with stroke? And the overwhelming majority of them identified a lack of standardized stroke education and training of EMS on clinical examination of patients with strokes, and education and clarity about triage protocols. So for a combination of approximately 70%. There is a history of EMS education. So this all goes back to the 1950s when the American College of Surgeons developed the first training program for ambulance attendants. Subsequently, in 1966, Highway Safety Act was passed, and that required each state to adopt highway safety programs to comply with federal standards, including emergency services. And in the 70s, funding was secured through a partnership between Robert Wood Johnson and the federal government for developing regional EMS systems. In 1973, EMS Act was enacted by Congress, and this provided more than $300 million in EMS funding over 8 years that allowed for systems planning and implementation, and actually mandated the states to focus on EMS personnel and training, and resulted in legislation and regulation of EMS personnel levels. The National Highway Transportation Safety Administration formulated a national standard curriculum for EMT and paramedic in 1977. And they also hosted a training workshop in the 1990s where they introduced curricula and introduced assessment-based education concept. In the late 90s, a vision statement was created by 2 EMS organizations where they described integration of EMS into healthcare system, and this too was funded by National Highway Transportation Safety Administration, HRSA. Fast forward to 2000s, Education Agenda, a systems-based approach, was also funded by the NHTSA, and this developed an integrated system of EMS regulation, certification, and licensure. And as recently as 2021, a revised guideline was published to define the entry-level education requirement for each level of EMS clinician. As Dr. Fifi mentioned, while the guidelines are minimum standards, minimum education standards for EMS, the content is not federally mandated, and it's left up to state and local agencies to use the guidelines to develop their own. So for EMTs and paramedics, the breadth and depth of stroke education is foundational and fundamental versus comprehensive and complex. However, when one of the registries that monitor the knowledge base of the paramedics and EMTs is assessed for implementation and adoption rates of all the metrics that are part of the AHA stroke chain of survival, not counting the field triage tool utilization, it amounts to under 1%. So clearly, while there are guidelines, education is a glaring need to improve our first responders to be able to use these tools effectively to improve access to thrombectomy. So what is the scope for a day on the Hill? To raise awareness for this issue on the Hill and to seek to standardize education for LVO stroke triage. And the reasons are, as was outlined, you have many patients who suffer stroke, and 25% of them develop strokes due to occlusion of a vessel, for which mechanical thrombectomy might be a successful and effective treatment. And yet the treatment rates are dismal at only 25%. 50% of the population resides within a 60-minute driving distance and 65% by air or ground, and yet too many futile transfers are happening based on some of the globally published data because the patients are coming in too late due to lack of recognition and not being transported to destination facilities. The heterogeneity in local and state EMS guidelines might be part of the reason why the patients aren't going where they need to go. And 67% of the EMS, despite getting training, had limited knowledge of how to use these tools. So the hope is that we'll be able to have our first mission thrombectomy day on the Hill on July 14th this year. And the plan is to create content outlining some of these high-level concepts with an infographic outlining epidemiology, the available treatment options, which really are standard of care but remain quite uncommon, and highlight some of the EMS gaps and proposed solutions. And also create a one-pager content narrative for outlining existing data and tools to state the case. Additionally, compile solicitation letters to seek meeting with legislators and have our stakeholders reach out to the legislators, and this would involve engaging constituents for effective advocacy, so patients, clinicians, survivors, families, our EMS partners, EMS Eagles, NAEMSP, to join this effort. So this might be what an infographic might look like. That's something that we're working on. But the key is to recognize that adoption and utilization of pre-hospital triage of LVO stroke can increase 4 times the odds of the patients getting mechanical thrombectomy treatment access. And education is something we can do today while we await development of additional infrastructure to improve access to those who are far away from such care. So I'd like to ask you to save the date, July 14th. And I would like to thank my collaborators, Ankita, Brijesh, Fawaz, Ayushi, Marnav, and Fred. And thanks to the MTCC, SVIN, Eagle, and NAEMSP.